All right, good evening all, and welcome to a webinar on pressure ulcers and heel protection. My name is Harish Mittal. I'm from REHACARE. REHACARE represents ProLevo from TALAR MADE in Australia and New Zealand. Moving on to the webinar session, it'll be presented by Barry Emms. Barry is a sales director at TALAR MADE UK-based company. He has years of experience working with NHS on the subject of prevention and treatment of pressure ulcers. Please free to ask questions using the link on your screen. You can do this anytime during the webinar, and Barry will answer your questions. Please don't hesitate to contact me if I can be of any assistance. Without taking too much of your time, I will hand over to Barry. And thank you again, and welcome. Over to you, Barry.
Thank you, Harish. Good evening, everyone, from a cold and wet morning in Derbyshire in England. I'm going to, Harish has given me a lovely introduction there. As you can see, I'm going to start a slide presentation. And I'm going to ask Harish to change slides for me. So we go to the next, please, Harish. That's me, that's my email address. And the beginning of the presentation, I'm going to just bring up a little quotation there, which you can all read. And that quotation was from, obviously, you may have worked it out by now, Florence Nightingale. What I'm going to present to you here is some very up-to-date data prepared by a lady called, a very talented lady called Claire Payne, who is the Knowledge and Evidence Service Manager in the Quality Academy at Warrington and Halton Hospitals NHS Trust up in the northwest of England. Rather than read everything on slides that you can see in front of you, let me just give you a bit of background here. Between April 2016 and March 2017, almost 98,000 NHS inpatients experienced pressure ulcers. Of those, almost 21,000 were newly acquired, which equates there to, you see, between 1,300 and 2,000 a month. There are prevalence of pressure ulcers. You may have heard of the Stop the Pressure initiative, and later in the presentation I'm going to talk to you about CPR for feet, which is an NHS Scotland initiative. We had in place, it's no longer with us, something called the safety thermometer, whereby avoidable harm to patients was recorded. And via this, a lot of the data was picked up, but you can see the total cost for the NHS per day is absolutely huge. And the cost per pressure ulcer, whether that's a category or grade 1 up to category or grade 4, is anywhere in that range. Pressure ulcers occur in the community as well as in acute care. And as you can see, there are some pretty big numbers there too. On the right-hand side is actually a reference to the safety thermometer. And you can see by far the largest prevalence in reports of avoidable harm fell under the heading of pressure ulcer versus fall, UTI or DVT. Next slide, please, Harish, which will show us the references for that data. Next one, please, Harish. So Claire Payne in her work looked at deconditioning, and again, I always try to avoid reading slides out, but you can read them for yourselves there, how quickly pressure ulcers can develop. The key figure there is the extended length of stay, 5 to 8 days. Deleterious effects on nearly every organ system. more likely for the sufferer to develop disabilities in activities in daily living, etc. And obviously, because of the lack of movement, patients unable to ambulate, decline in muscle mass, strength and power, decrease in aerobic capacity. And you can see those numbers pertain in 70 days of bed rest. And of course, a hot topic is cognitive function at the moment and the effect. And you can see there it's a deleterious effect on cognitive function too. Next slide, please, Harish, which is the references to that work. So looking at the human cost, I think you need to go back one, Harish. There are the obvious things, aren't there? You know, pain, lack of sleep, lack of mobility, lack of independence. I've talked about the activities of daily living being decreased. Psychologically, these are big areas, aren't they? You know, privacy and dignity being compromised, uncertainty being placed upon the individual feeling that they're a burden, creating anxiety, which is leading to an estimation of 80% cases of depression, especially in the elderly. And if we look at mortality, the figures there speak for themselves, with a reference at the bottom to The Heart and Superman, and that's reference to Christopher Reeve, the American actor who played Superman originally, whose death certificate, I think, stated that pressure ulcers played a large part in his demise. And on the right-hand side, you can see those sort of psychological and social effects on patients who have the burden of living with pressure ulcers. Thanks, Harish. Next one, please. And again. So here's a question that clinicians ask themselves, especially nurses. Am I looking at a pressure ulcer or moisture lesion? Because there's often confusion. And this is the best thing I've found, actually, that clearly gives that definition and divides a moisture lesion from a pressure ulcer, from causation, location, shape, depth, and necrosis or not. I think the easiest way I talk to nurses about identifying whether there's a pressure ulcer or a moisture lesion is location, first of all. Pressure ulcers occur over bony prominences. Moisture lesions are found where there's incontinence and or perspiration. And the shape is the giveaway usually too, where a pressure ulcer is usually distinct, oval or round in shape, and the moisture lesion has an uneven, diffuse edging and shape. And as an example, there's some examples on the next slide. And I'm sure you'll be able to identify between those. That's the top left-hand corner is the classic kissing moisture lesion, found in the buttocks usually, moisture lesion below that, and on the right-hand side, a big, deep, angry-looking, horrible sacral pressure ulcer. In the UK, we have the National Institute for Health and Care Excellence, and they issue guidelines. This is their statement or their guideline on pressure ulcers and their prevention and management. And noting that there's a separate nice guideline for what they call diabetic foot problems. So here's the question. Why do we protect heels? Well, the heel anatomy and physiology works against us in terms of preventing pressure ulcers. The bone, the calcaneus, is the largest in the foot. It's an angular bone. It's not smooth. The thickness of skin at the heel is thin. In a supine position, there's sustained high pressure over a very small contact area. And I'm sure those of you who are familiar with pressure ulcers on heels will identify with the fact that the pressure ulcer starts locally in a very small area and then rapidly spreads. Those of you dealing with the diabetic foot will know that the skin will thin also with diabetic neuropathy in place. I talked about the supine position, and there are not just the forces of pressure, but friction and shear forces when sliding down in bed, or even with the agitated patient in bed. More physiology here pertaining to vascularity. We know that blood flow to the heel comes mostly from the posterior tibial and peroneal arteries. And we can see there just how thin the soft tissue layers are. And the bottom line is that the heel isn't very well protected from pressure, friction, or shear, and rapid damage can occur. And this is what we're trying to avoid, of course. So let's have a look at the rationale here. Well, heels should ideally be free of all pressure. And of course, if we think basically, it's the only part of the anatomy that we can take the pressure away from completely whilst in bed. If we could get bottoms and shoulders in the air, that would be wonderful, but impossible at this stage. So heel suspension devices are preferable for long-term use. And for those patients unlikely to keep their lower extremity on solutions such as pillows. Pillows are widely used and still widely used in the UK, but less so now than they were many years ago. The problem with a pillow is that patients fall off them. And I don't think I've ever come across a patient yet that will actually reposition themselves for me. So heel suspension devices selected should be based on clinical conditions. Patient tolerance is a big area, and using the manufacturer's guidelines. Now, not all devices are to be worn in bed. If you're putting a boot on a patient with contractures, that's difficult and may not be sensible. And also putting boots on patients with a lack of sensation or inability to communicate may contraindicate the use of a boot. We must also consider the patient who may be at risk of fall, because if we strap boots to their feet and they get out of bed, we're heightening the risk of fall because the boots are pretty slippery. So there's a heel beautifully floated using a pillow. But as I've just stated, pillows aren't ideal in a lot of cases. I think one of the problems I come across working in the NHS in acute settings is the lack of available pillows is one problem. So I'm going to run through the solutions that we manufacture. I'm going to start off with our basic devices. The Safeguard foam boot is a convoluted foam boot supplied in a pair, either left or right feet. They're universal. And what the convoluted foam does is to redistribute the pressure on the heel. So it doesn't elevate the heel, doesn't take all the pressure away, but this is a popular device as the first leg on a pathway to care and protection and prevention. I see these used on short stay patients in the acute setting who are deemed to be, through a skin scoring system, at low risk of pressure ulcer. Mainly used in orthopedics, where patients are admitted maybe for joint replacement, especially hip replacement, where the patient's stay is less than 2 days normally, if all goes well. So it's a good sort of safety first device that's inexpensive, well tolerated by the patients, and disposable. In addition to the foam boot, next slide please, Hannah. We supply a pad. Now these come as a pair as well. Same material, convoluted foam, single patient use. I'll stress again, these things aren't washable. They're for short-term use. The pad can be placed at the foot of the bed to rest the heels on, where the patient may be at risk of fall. So it may be a patient with delirium who may get out of bed wearing the boots and not take them off. Or it could be that, that hip replacement patient who quite rightly is in and out of bed quite a lot post-operatively with the physios being mobilized quickly, where the boots on the patient become a bit of a hassle. So when the patient gets back into bed, they're resting their heels on these things. The pads can also be used between the limbs, where you'd normally place a pillow to prevent moisture lesions occurring. They can be cut to shape, cut to size. They're less bulky than a pillow, and they allow airflow as well, which is ideal when trying to avoid moisture damage. I've seen them cut and put into pillowcases to rest heads on, and even put behind the back of patients with bony spines or spinal deformities when they're sitting out in high back chairs. They're just another layer of protection for the spine. So it's a utility pad and it has lots of uses. Now onto Heel Pro. Now this is our most popular heel protection product in the UK. It's a single patient use bootie, which is designed to elevate the heel. It is either left or right. We provide them as single boots. Most often you'd be placing a pair of these onto a patient, because if one foot's at risk, the other's bound to be also. The reason that we'd supply them as a single was that we produced these initially for community nurses who were putting two, one on each foot on their patients, but often had to replace just one of them. The anecdotes I got back from district nurses were that these things were eaten by dogs, or set fire to with cigarettes, or became soiled in one way or another, or the grandchildren played football with them and lost them. They've got lots of stories. But supplying them as single meant that the nurse didn't have to buy a pair or requisition a pair when they only needed one. So we still supply them as a single boot. They have a soft lining. They're well tolerated by patients. They're easy apply, and are single patient use. They have quite a long life too. Thanks, Harry. Now, recently as about 2 years ago, we introduced Heal Pro Advance. Now, Heal Pro Advance is the same product, but it has a wipeable cover. The cover is manufactured from ripstop. Now, this is indicated for use where the patient has an existing wound that may be leaking, striking through a dressing. It may be placed onto an individual with leaky legs, with vascular ulcers, etc., where the original Heal Pro, being soft, is quite absorbent and stained quite easily. So we have hospitals and community teams running with Heal Pro and Heal Pro Advance now. And Heal Pro Advance, like I said, is indicated for use where there's an existing wound. It's just easier to keep it hygienically clean. So that's Heal Pro Advance. Thanks, Harish. We've had a few publications around the use of Heal Pro. This was a poster that appeared, I think, in 2018 at the Wounds UK conference put together by a team down in Kent. Copies of all of these things will be made available to you. You just have to ask, and please do. The next slide, please. The most recent piece of work was published in Wounds International recently, and contains the use of Heal Pro and Safeguard. This is Medway down in Kent, who have an equipment pathway for the prevention of pressure ulcers on heels and for the treatment of existing pressure ulcers. And they'll use Safeguard, as I pointed out, that convoluted foam product, on the lower risk patients or the shorter stay patients, and then we'll progress to Heal Pro where the patients are at a greater risk or with them for longer. And sometimes patients will actually move from the Safeguard boot into the Heal Pro boot if the Safeguard boot isn't giving enough protection. Thanks, Harry. Now, I mentioned CPR for feet in NHS Scotland. The person behind this initiative is a chap called Duncan Stang, who's the lead for diabetes in podiatry in Scotland. CPR standing for not cardiopulmonary resuscitation, but check, protect, refer. I'm going to play a short-ish video a little later, which will explain far better than I can. But the initiative is aimed at all clinicians now to ensure that feet are checked on admission, feet are checked on patients in the community once they're referred into nursing or podiatry, and feet at risk are protected, and certainly that patients are referred on, if need be, either into tissue viability or podiatry if there's concern about feet. Next one, please. There's an algorithm that's been put together in terms of selecting the correct product. And if you keep clicking, Harish, it'll fill itself in. So on one side, we're looking at low-risk patients, with the next question being, is the patient ambulant or not? If the patient's ambulant, maybe we will fit a device to the bed. If the patient's non-ambulant, the patient may wear a device. And on the other side, where there is damage, then we still ask the same questions. Are we going to, is the patient ambulant or non-ambulant? And that will determine which device is most appropriate. Thanks. So we're going to play this video now, and hopefully you'll be able to see and hear it.
principal aim of this learning resource is to raise awareness of the importance of CPR for feet and how to apply CPR to individual patients or clients in a health and social care setting. The introduction of the resource will help staff working in health and social care settings to understand the overall need for appropriate foot checks, appropriate protection and appropriate referral. I need to check your feet today. Is that okay with you? It's important we look between the toes because there could be some hidden abrasions. Right, your skin seems intact. I just want to check your heels. That one's fine. And I just do a little test called touch the toes. Okay. So if you can close your eyes for me, please. And I just need you to say yes if you think I'm touching you at all.
Oh, I got that.
Okay.
Pressure ulcer prevention and patient safety have become a key objective within the UK, where the NHS has adopted a zero tolerance approach. Pressure ulcers represent a major economic burden to healthcare facilities, and over the past 20 years, a strong emphasis has been placed on early detection and prevention. The UK is estimated to spend 4% of the annual national healthcare budget on prevention and treatment of pressure ulcers, and has reported the daily cost of treating a pressure ulcer to range from £43 to £374. These costs are in addition to the cost of standard care. The development of a pressure ulcer can increase the inpatient length of stay of between 5 to 8 days per pressure ulcer and up to 13 days in the case of a person with diabetes. A national audit conducted in November 2013 of 1,048 inpatients with diabetes across Scotland revealed that 2.4% of inpatients with diabetes developed a new foot ulcer while in hospital. It also highlighted 57% of patients had not had their feet checked, and 60% of the patients at risk of developing a foot ulcer had no pressure relief in place. The financial pressures on healthcare providers is significant, with data from a range of healthcare settings indicating a prevalence rate of pressure ulcers from 4.7% to 32.1% for hospital populations, 4.4% to 33% for community care populations, and 4.6 to 20.7% for nursing home populations. Further data has shown that between 4 and 10% of patients will develop a pressure ulcer following admission to hospital. Pressure ulcers also have a significant impact on the quality of life and morbidity for all groups of patients. So a campaign called CPR for Feet has been launched in Scotland. So what is CPR for Feet? This is a recent campaign devised in Scotland and was originally a campaign designed only for people with diabetes being admitted to hospital, and has now been extended to include many other risk groups beyond just people with diabetes, and to include other care settings than hospitals such as nursing and care homes. The aim of this campaign is to eradicate avoidable acquired pressure damage to the heels of patients and adopt a zero tolerance approach. The campaign is to ensure that all patients on admission to hospital or other care setting have their feet checked and assessed for risk of developing avoidable pressure damage which may lead to an ulcer during their stay. If they are at risk, they are protected with the appropriate pressure relieving device, and if they have an existing foot problem, they are referred to the suitable healthcare professional to treat the problem according to local guidelines. Avoidable hospital-acquired pressure damage to the heels is unnecessary, can lead to litigation, and is easily avoidable. it has been proven across the UK that the use of successful preventative pressure redistributing relieving strategies can greatly reduce the associated healthcare costs, as the use of such strategies to improve patient care is very cost effective and improves the quality of life for patients. CPR for feet is a very simple concept which is being effectively introduced in acute hospitals and other care settings across NHS Scotland. After the success of this campaign in acute hospitals, this initiative is now being implemented in more community-based settings such as nursing and care homes, where a large proportion of residents have diabetes or other conditions which make them susceptible to pressure damage. This online training package has been developed for all levels of staff to raise the awareness of this issue. This training module will teach staff how to check feet for any existing problems, for neuropathy and other risk factors that the patient may have of developing avoidable foot ulcer or pressure damage, to teach staff how to introduce the appropriate pressure relief strategy to protect patients according to their individual needs, and how to refer the patient appropriately when an existing problem is discovered.
Check is shown by a practical demonstration of a foot examination. This demonstrates the foot examination to identify current foot pathologies and/or an at-risk area.
Josie Martin is being admitted to hospital today for minor elective abdominal surgery. Josie has some ongoing health concerns, including minor heart failure and developing arthritis. She has 2 children who live down south, and in a month's time her son is getting married. Josie wishes obviously to attend the wedding and to dance with her son on his wedding day.
Hello, my name's Beth. Can I just check that you're Josie Martin?
That's right, that's
Thank you.
me.
I'm one of the healthcare professionals here who'll be involved in the team looking after you. I need to check your feet today. Is that okay with you? You have some health concerns, and it's important that we check your feet to make sure that we avoid any pressure damage. Okay?
Okay, that's
So
fine.
it'll just take a little while to do. We check between the toes. It's important we look between the toes because there could be some hidden abrasions. Right, your skin seems intact. I just want to check your heels. I have this little mirror, so I don't need to bend too far. That one's fine. Okay, that one's fine. I need to check now what you can feel with your feet. And I just do a little test called touch the toes. Okay. So if you can close your eyes for me, please. And I just need you to say yes if you think I'm touching you at all.
Oh, I've got that.
Okay.
And that.
Okay, I'm just going to document it. Documentation is referenced throughout the resource. Documenting the findings and actions of the foot assessment are essential. If it is not recorded, it did not happen. Different settings and teams may use different documentation. The important thing is that the information is recorded for care planning, to communicate with others, as a legal document verifying care delivered and care needs ongoing, and also if referring on is necessary.
So what patients are in the at-risk groups? The frail, the elderly, patients who have a vascular deficit, patients who have diabetes, patients during surgery, post-operative patients, and patients who are bedbound. When the decision has been made that we need to protect our patients' heels against pressure damage, we then need to decide what is the most appropriate and effective pressure relieving, reducing strategy to introduce. The at-risk patients fall into two distinct groups: those who are ambulant and are independently getting in and out of bed, and those who are non-ambulant or bedbound. And for these patients, we either need to fit a device to the bed called a heel safe, or fit a device to the patient called foot safe. If we just need to reduce the pressure on the patient's heels to avoid any pressure damage, then the heel safe device fitted to the bed can be sufficient. The advantage of doing this is that in many cases the patient is even unaware that any device is fitted to the bed, so concordance is not an issue. If we need to relieve the pressure on the heels completely, and even if the patient is on a pressure-reducing mattress, we may need to apply a foot-safe boot or boots to further reduce the risk of pressure damage occurring. These boots are not suitable for ambulation, and if the assessing clinician feels the patient will try to walk while wearing the boots and thus create a falls risk, then a different device might have to be sought from one of the other specialities to ensure patient safety. If the patient slips down the bed, resulting in pressure being put on the plantar aspects of the feet from the bed end, then a sole safe can be fitted to the bed end to protect the patient. All the devices mentioned have been tested and approved for quality, durability and cost effectiveness by various healthcare professionals, including infection control, and are available to order from the National Distribution Centre via PCOS. The heel safe and sole safe can be easily disinfected like any mattress in accordance with manufacturer's guidelines. The foot safe boots, although disinfectable, having passed infection control guidelines, are generally used as single patient use, and it is advised that when the patient is transferred or discharged from their care setting, that the boots remain with the patient.
Protect has a devices algorithm. Following the practical demonstration of foot examination, an appropriate device is selected by following the algorithm, and application of the device is demonstrated.
Following Josie's admission to hospital, there are two different scenarios that can take place. Josie's feet are not checked to assess her risk of developing avoidable pressure damage during her stay, and no pressure relieving strategy was implemented. This resulted in Josie developing avoidable pressure damage to her right heel, which became an ulcer. This caused Josie considerable distress as it delayed her discharge from hospital, and hence she missed her son's wedding.
Josie's feet are checked to assess her risk of developing avoidable pressure damage during her stay. Josie was assessed as being at risk and had a pressure relieving strategy implemented, and Josie did not develop any avoidable pressure damage during her stay and was discharged in time for her son's wedding. We have described and demonstrated how to check feet. We have described and demonstrated the use of protective devices. The third part is referral. Referral will be required if the patient has existing pressure damage or another problem with their foot which requires specialist input. This referral may take the form of a telephone call, an email address, or track. It may involve podiatrists, tissue viability nurses, or orthotists, depending on local protocol. Irrespective of the means of referral or who is involved, it is essential protection is put in place immediately to prevent further tissue damage. Referral guidance will vary between health boards. It is essential you know what is in place for your locality.
Remember, if you spend 30 seconds checking the patient for risk of developing avoidable pressure damage, you can save the patient from having to spend an extra 13 days in hospital. So spend 30 seconds and save 13 days.
Thanks, Harish. I hope you all saw and heard that. Please ask any questions as I'm coming towards the end of the presentation. I'm just going to give a quick run through of the products that you saw there. We developed these products with the teams in Scotland to fit within the algorithm of CPR for feet. This is the foot safe boot. It comes either pre-inflated or inflatable with a pump, and in various sizes from child size all the way up to extra large, and is easily cleaned and disinfected. Now the boot is obviously fitted to the patient who's either non-ambulant or able to take the boot off when they get out of bed to prevent themselves from falling. The heel safe is a bed fitted device, normally placed on top of the mattress with the sheet drawn over the top. It's inflated to 20 millimeters of mercury, which has been pressure mapped and tested to alleviate pressure best on the skin. And you saw its use in the video. So ideal for that ambulant patient or the patient at risk of fall. And the next product you'll see is Sole Safe, here shown together with Heel Safe, which is proved to be very popular through the whole of the UK, whether boots are worn or not, to overcome this problem of patients migrating down beds and feet ending up on the bed plate at the foot of the bed, and pressure ulcers being caused there. I see these especially used on diabetes wards now, because, as you know, the risk of diabetic foot ulceration is extremely high if feet touch the end of the bed. There's another device in there which is commonly known as a PRAFO, pressure relieving AFO. This is our variety. There are others around too. This is a rigid frame device which, worn in bed in the supine position, will actually elevate the heel, but has a non-slip pad which allows the patient to ambulate in this device too. So for some patients this is ideal. So there's the full algorithm showing the devices recommended under each of the pathways. Thanks, Harish. So a few links there, linked to the company, TALAR MADE. We have a separate website for ProLevo, which are the devices that I latterly showed under the CPR for feet heading. And there's a website which is in development at the moment for Heel Pro. Few links here. There's the link to that learning module which the video was taken from. The touch the toes test is, you may recognize as the Ipswich touch test. And that's shown on YouTube as well. But importantly, we have our own pressure care channel on YouTube, which will show how devices are fitted. So they give great fitting instructions there. If you're unable to record these links, I'm sure if you let Harish know, he'll be able to mail them to you. And I don't mind if you come direct to me. My email address is there at the bottom as well. So if you need those links or any more information, please come direct to me or to Harish or through Harish. Thanks. I'm just going to have a look at the chat at the bottom here. I've got a couple. Anne's asking me to show how to put the Heel Pro on. And I'll refer people to the video. I'm unable to do this at the, I don't have a Heel Pro with me, but the videos are excellent, and they'll show anyone how to apply these things, to don and doff them. I don't know if there are any other questions anyone would like to ask. Hello again, Harish.
Hi, Barry. Thanks again for your time. All the attendees, if you have any questions, you can ask now, or you can email us, and we're more than happy to provide you with the information. Again, I don't think there's any more questions for you, Barry. There.
Thank you. Well, thanks for inviting me. Lovely to be part of this. And as Harish has said, and I've said, if you do need any more information, any help, please go through Harish. And you saw my email address there too. So please email me direct. I'll be pleased to help.
Thank you, Barry, and have a good day, and good evening to everyone in Australia. Thank you.
Thanks. Bye-bye.
Bye-bye.